scope, so most of the hysteroscopic GYN procedures. It's going to be kind of a rerun through for most of you guys. We're just going to walk through the basics, best practices of this fluid management machine. Just make sure you guys are good to go. Not here as much as I'd like to be, so just getting you guys ready to rock and roll. So I will ask someone to come up and be my scrub today. Anybody who has experience with this or wants to come help me, that would be fantastic. If not, someone's gonna get called up to come work with me. There we go, perfect. And then questions throughout, anything you guys have seen, troubleshooting, anything that's come up during a procedure, just let me know and we can talk through that. I'll be around the rest of the week too, kind of coming in and out of these cases, so feel free to grab me, but we'll just jump ahead. So first thing, we have these check marks. First thing I'm going to do here is put our saline on. We use 3-liter bags typically. For today I'm just going to use a liter. Throw that on there as you see our check mark. Next we'll get this Lucent flow pack open, and then this comes non-sterile on the outside. We're going to go ahead and just put that right there. Check mark good to go, and then I'll have you go and get our scope set up here if you would like. So we're getting our scope set up. One scope, you guys don't have to worry about that. It's just the same scope every single time. Yep, I do got the nipples here. So we got our MyoSure seal sets right here.
Are those yours?
You got these?
Because we only had 4 up there and they're on order.
They are?
Yeah.
Okay, so we're not going to use
nervous.
those today.
Sorry.
We're not going to open them today. No, good call out though. But yes, make sure we use these every single time. And make sure too, when you're done with the cases of scrub, take them out. I get told by my sterile processing people all the time that they get these with people in them and then they got to re-sterilize them. So we'll go ahead and these go in nipple forward. So she's good to go with her scope there. And we can go ahead and get our flow pack opened here. Go ahead and pass it off to her. Perfect, and then everything, we're just following the check marks on the screen. So pretty self-explanatory, but there's a way to do it and an order to do it, which we'll go through today. So I'll go ahead and have her just pass it off to the circulator here. Good to go. You can go blue or yellow, either order. But we'll just pop this in. Good to go. A note here too, sometimes, I don't know if you guys have come across this, but these are off track and you can't push these in. If that's ever the case, all you need to do is turn the machine off and turn it back on. These will rotate back to their original spots. Or you can just manually manipulate these a little bit and get them on track. So that's one way to do it as well. I would recommend turning it off and turning it back on. Most of the time I see this is if there's multiple cases in a day, if you don't turn it off between cases, these are gonna be in the spot they're not supposed to. So make sure you're turning it off and turning it back on between every case to get those aligned. So good to go, we got our yellow. Pop that bad boy in, perfect, we got all our check marks. I see this quite a bit too. We want this bad boy here directly in line straight up. If there's any sort of kink at all, it'll pull this bag up and you'll get a waste bag missing. This is all based on weight, both of these are. So if there's any extra weight or less weight than it's supposed to, you're gonna get an error message. So make sure it's completely vertical, no pressure on that at all. And it's just a push on as well. A lot of people feel like it's a screw on. It looks like it should be a screw on, but it's just a push on. Yep, and completely vertical. Good to go. Go ahead and get our bag spiked. This is one of the more important things I'm going to talk to today, so if you forget anything, remember this right here. I make sure that the circulators and scrubs always have these clamped, and to keep these clamped until I tell you otherwise. So I'll show you that here in a sec. Get this bad boy spiked. I'm not used to these ones. They just pop through right there.
Yeah, just push it right through. Or we usually have like a basin for those too, so that we have some of water.
Yep, correct. So we're going to use our little plastic as a basin today.
Okay.
But okay, so we're good to go. Keeping this clamped. That's the biggest thing. Pay attention to right now. So we can go ahead and get our scope tied on. So if you want to show them that blue.
The blue goes on top because
Yep.
it's inflow, and then the yellow goes on the bottom because this is where it comes out at.
Yep. So I always think of it blue inflow, fluid, water going in, yellow outflow, going out. So our outflow channel is the one on the back. That one comes in and out, so that's going to be our yellow. So you can get those taken off there. And then
I'll
this.
pass this one off.
Yep.
too.
So this will get passed off. This is going to our under buttock straight. So this is important. We want to make sure this is completely flat on the ground, not over the leg, not hanging over anything. completely fat on the ground because it's gonna come back into the machine. So we'll just go ahead and drop that here for now. So scope set up, good to go. Still keeping these clamped, okay? So I'll show you why here in a sec. So we're good, we got all our check marks. I'm gonna go ahead and press next. You hear those locking into place. If this is unclamped before those are locked into place, we'll get fluid into these right here and it'll cause this to want to pop out during the procedure. I don't know if you guys have seen that, or it'll leak fluid. I've also had a couple machines go down where that was their standard practice. They unclamped it too soon, fluid got in here, the machine got overloaded with fluid and we had to get a new one. So make sure to keep these clamped until the machine says unclamp bag, okay? So we're good to go. Now we can go ahead and unclamp. You might get a little, we don't have the seal caps, so she might get a little wet here, so be careful. But we're good to go. Go ahead and unclamp. We can prime that. So a little note here when we're priming too, it's easy to just put it in there, put it straight down or whatever. We want to make sure it's pretty similar to how the physician is going to enter it into the cavity, the uterus, cervix or whatnot. Because what's this doing? It's not only purging the air, but it's showing the correct flow through the scope and the angle. So we want to make sure we have an angle that's going to be used during the procedure. This is good to go here. While this is going on, we can go ahead and put our foot pedal on. I always like to get the foot pedal by the physician's foot right away. They use it probably, I don't know what you guys are seeing, but at least 75% of the time this machine's used, a myosure is going to be used. We can go ahead and get that foot pedal by their foot. Okay, we're good to go, and go ahead and press next here. So now, since you guys prime before the patient's in the room and we do it in a basin outside of the field, we're gonna go ahead and zero out our deficit. So how we do that here, reprime 0, 0 up top, yes, good to go. We can go ahead and exit. So if we primed into the under buttock straight, you guys are running behind or you didn't get a prime before, we would not zero that out, right? Because that fluid's gonna suck back up into the machine and be accounted for into our fluid bag here. So pretty much every time you guys are gonna zero that out, but every once in a while, I'll see you'll have to prime into the under buttock straight, then you will not zero out that deficit because it will get circulated back in. So pretty much good to go here. These are our presets for our deficit limit. So a max deficit limit is 2,500. Machine shuts off, procedures over at that number. So it's important to let the doctor know if you guys are approaching that number, just so they can prepare for the rest of the procedure. And then any number this deficit limit is set at, the machine's gonna stop. So if you feel like they're losing a lot of fluid or that deficit's running up, just constantly look at it and let's bump that up during the procedure so it doesn't come to a stop.
What if like they didn't use all that fluid and now the fluid is just running and keep running and running and then it messes with the deficit? Is there a way to stop the fluid from running from the saline into like the catch bag and stuff? Because that's the issue that we're running into. We're getting water everywhere because it's just running and running and running. It doesn't stop.
Yeah, I would say one way to deal with that is if they're not using the scope at all or they're not using the myosure, pause the machine. So, they're kind of going back and forth between the scope. A lot of times during the procedure, they have to put another tenaculum on, they got to dilate a little more. If that ever happens, pause the machine so we don't get that fluid constantly running.
Yeah, but then it's not sucking up the fluid that's in the bag if you pause it too. So then we're not counting what's in the deficit.
I see. So it's in the bag and it's showing a higher deficit.
Yeah.
That's a good question. So if that ever is the case, what you can do, you want to pop that outflow channel out.
Okay.
You can, just go ahead and take it out.
Thank you.
Yeah, absolutely.
Yeah, thanks.
No, you're totally
Okay.
good. I mean the whole thing, so you
just
can
take
leave
the
that.
whole thing? Okay.
So you can leave that on.
Okay.
So go ahead and screw it back on.
Okay.
So her question was.
Okay, take it off.
Yeah, go ahead and take it out of the back.
Okay.
Yep. You got this.
Okay. Yep.
So her question was, our under buttock strape is full. It hasn't sucked back into here yet because it's one suction rate, so it's not going as fast as we can, right? So if they're losing a lot of fluid into the under buttock strape, our deficit is going to show higher than what it really is. So what she's asking is how can we circulate that back in to get our deficit down? So what you can do is take the outflow channel out. You can go ahead and hold that up. So you take it out of the back of the scope. If you put that outflow channel in the under buttock strape, it'll suction twice as fast, right? Because it's going to be suctioning from there and it's going to be suctioning from the underbody
Gotcha.
straight tubing.
Okay.
Yep.
Okay.
So if you see that, you could just say, "Hey, doctor, let's take a quick second, real quick. We're gonna get the fluid back into the machine to get our deficit."
And then just stick this into the bag.
Just stick it into the bag and
Thank
plug
you.
it up. Yeah, absolutely.
Okay.
And then also, you can do that with the MyoSure as well. So say
Oh, no.
they're using the MyoSure and the same thing's going on. What the doctor can do is just put the MyoSure into the bag, press this foot pedal, and it'll use that suction to suck the fluid out of the underbody straight. So either way. But I would recommend as a scrub, when they are using the MyoSure and they're done, because we take that outflow channel out when they use the MyoSure device replaces it. Just go ahead and put that in the underbody strip with it open, and that way it'll be a double suction throughout the whole procedure.
Okay,
Yep.
awesome.
So yeah, so that's our deficit limit. Just make sure to watch it. 800's the preset, but we can go from there. Pressure, 80's the preset. I don't know what you guys see. We don't ever really go above 100. So what that is just for visualization, just to kind of spew that water around and get a good visualization in the cavity. But if they ever ask to bump that pressure up, that's just right here. We can go up to 120. I always like to keep it just above the mean arterial pressure, so I'll ask the anesthesiologist in the back what our mean arterial pressure is and kind of keep it just right above that. That's kind of a landing zone for me. But that's the physician, what they want. They want it up or down.
We do have some students in them, so can
Yeah.
you explain like why we use this machine?
Yeah, so fluid management. So this is being done in a hysteroscopic procedure. So her question was, why do we use fluid management, right? Great question. So essentially we're calculating how much fluid is lost into the patient, right? So in these procedures, we're pushing fluid into the uterus and it can be lost into the body, for example, through the tubes or through perforation, or some anatomies just absorb water a lot quicker. So that can be unhealthy for a patient. So what this is doing is just calculating how much fluid goes in, how much fluid goes out, so we know how much has gone in, essentially. So for years, this wasn't used during hysteroscopic procedures. Now this is the standard of care, standard of practice, and this is used across the world for these procedures, just for that safety component. So that answers your question right there. But yeah, that's essentially it. So what we'll see here, I'm not gonna run it. But are there any troubleshooting errors that you guys have seen, or anything you guys have questions on with this procedure that have come up? She had a good one there. Those are pretty much the main things. What I really want to point out is if there's multiple procedures in a day, make sure to turn it off and turn it back on. This clamping component, make sure this is clamped until the machine tells you not to. That's where most of the errors occur. Tubing, we want the tubing under the leg every single time. We want that nice even flow. If it's got to travel up and over the patient's leg, it's going to mess with the inflow, the outflow, to mess with that visualization. So those are the big things there. If the doctor's not using the scope for more than 15 seconds, like I said earlier, if they're changing the tenaculum, dilating a little more, make sure to pause the machine. That'll help with not only our deficit, but just excess fluid running out. But yeah, those are the main things. I'm not going to open the MyoSure, but I'm sure as a lot of you guys know, this is the MyoSure device. So like we were saying, it goes into the back of the scope, so it replaces this outflow channel. Like I said, when we're not using this outflow channel, we can go ahead and put it in the underbuttock drape, and that'll help with that suction coming back up. But MyoSure goes to the back of the scope, and then there's two tubings. One will plug into right here, this tubing on the outflow, and then we just plug it into the machine there. So there's not an extra generator or anything. It's all just built into one right here. I don't want to open one and waste one today, but those are the main things that I have, main things I wanted to point out.
What are the types of MyoSures we have?
Yeah, good question. So you guys have XLs? I can't remember.
Yes.
You do have XLs?
And then we have one XL.
XL scope,
scope.
yeah. Yeah, so probably, there's 3 different MyoSures. Probably 75% of the time, you're either gonna be using a MyoSure Lite or MyoSure Reach. More so the MyoSure Lite, I would say. So this is kind of the basic, most inexpensive device right here. So that's gonna be used for small polyps and tissue. Essentially, that's taking the place of a blind DNC, right? So they're using that just to get the tissue out, get their good sample with small polyps and any tissue. If there's any fibroid, they're gonna go up to the MyoSure Reach. So the MyoSure Reach has a stronger bite, and the tip of the blade is closer to the end of the device, if that makes sense. So the tip, so say this was our device, the blade comes to the very tip, where with the light, it comes down to right here. So what that does, hence MyoSure Reach, it allows them to get to that more fundal pathology, up against the fundus essentially and towards the tube. So if there's any tissue that's tough to get to, that could be good for you guys to recommend too. Hey, maybe we should grab a reach if the physician's struggling. You would think they would know. A lot of times they don't really know the difference between these devices, especially if it's a newer doctor. So something you guys can point out. And then those are used for small polyp or small fibroids as well. So all polyps and fibroids, small fibroids for the MyoSure Reach, polyps, small polyps and tissue just for the MyoSure Light, and then the MyoSure XL is for larger fibroids. So anything above a 5 centimeter fibroid, we pull that XL for. So if it's indicated a myomectomy, I would make sure to have a MyoSure XL in the room, and then also a MyoSure XL scope. So this scope here, it's just our standard scope. There's another XL scope as well. So even if you're not sure you're gonna use it, you're gonna set up the normal scope, make sure to have that XL scope in the room, XL device in the room, if it's a myomectomy, if there's any fibroids, just in case we gotta bump up to that. A lot of times the MyoSure Reach can take down a large fibroid, but it's gonna take a lot longer and they might want the XL. So just have those things ready to go. Yeah, I think that's the